Assalamu alaikum and very good evening to all of the participants who have come here and joined us today. And at the beginning, I would like to thank Emirates Society of Internal Medicine for inviting me to conduct this very important session, not only for the internists, but for the neurologists and family physicians and general practitioners. I think over the last 2-3 years, Emirates Society of Internal Medicine has been doing a great job arranging a very regularly different topic-oriented seminars and programs, and which most of them they have been CME accredited. Today we are lucky to have a neurology session today, and to discuss the topic migraine, which we all know that for doctors it has been said that migraine or headache is a headache for the doctors to diagnose and to the treat. And when you talk of the headaches, migraine is the most common cause of the headache, apart from the tension headache, these things. But there are so many things missing the diagnosis as well as the management. And I'm sure today 2 eminent speakers, rather 3 eminent speakers will be discussing not only the etiology causes, as well as they will be touching some of the management aspects. The migraine, sometimes I personally I think it is one of the, just like we mentioned about the non-communicable disease like diabetes, hypertension, which may be prevalent in all the houses and homes. But I think migraine also, I'm sure, is such a common that every household will have at least 1 or 2 members who might have suffered at any time migraine. And it is being said that maybe it is the second or third most common illness. And in fact, it's one of the commonest cause of the sick leaves, apart from the back, due to backache and the migraine. These are the 2 commonest causes of these things. The important thing about the migraine, we all know that it affects the quality of the life. This is the very important thing, This is the main thing which causes worry, because everybody thinks it is such a simple diagnosis, but the one who suffers from the migraine, they can only realize how difficult it is to bear this diagnosis. So today we have 2 speakers, 2 eminent speakers. The first of all, Dr. Ata Ghassan, and then Dr. Nabil. He will be speaking 2 different topics. So it is just requested to them to, because of the time limit, so they have to limit their talk to 30 minutes. So at the beginning, I will be, I think, and after these 2 talks by these speakers, there will be a question answer section lasting for about 10-15 minutes, depending upon the number of the questions. I'm sure people will be very keen to ask so many questions. And once we finish the question answer session, we have got another important, equally important session, though that is a pharmaceutically sponsored, but nonetheless, it is very, very important. And the last session where we'll be discussing something about the management of the migraine. So just to beginning our talk, I think we'll be speaking today. The first talk is by Dr. Ata Ghassan. And Dr. Ata Ghassan he'll be talking about the topic is the migraine disease overview and the burden in United Arab Emirates. Dr. Ata Ghassan is the head of the neurology department at the Burjil Hospital, Abu Dhabi, and we all look forward to his talk. So over to you, Dr. Ata, please.
Thank you, Dr. Nayaz. Thank you for ESIM, and in fact, thank you for the organization company. To start with the migraine disease overview and burden in UAE, there will be small. My talk, it will be concentrating as outlines on abstract headache, migraine, and we'll continue according to the presentation. So to start with, migraines are a recurrent type of headache. They cause moderate to severe pain that's throbbing or pulsating in nature. It's not just headache, it's really bad headache in migraine patients. Migraine is a neurological condition that may cause multiple symptoms. Debilitating headaches, frequently characterized as additional symptoms may include nausea, vomiting, speech disturbance and tingling sensation, and according to the sensitivity of the light and sound. The condition is often in families and can affect all age group. Migraine imposes significant health and financial burden. Approximately 38% of patients with episodic migraine would benefit from a preventive therapy, but less than 13% take prophylactic medications worldwide. So our aim as physicians and neurologists will be preventive. The diagnosis accurately will be built, and the preventive medication therapy, in addition to treatment of headache in acute stages. So to start with headache, the head pain could be a mechanism or again a central mechanism through different pathways, including that external trigger evokes activity of the trigeminal-vascular afferents, which terminate in the lower brainstem and increase and hence affecting the central mechanism, stimulating the pain patterns. Again, according to the classification of headache, it will be primary or secondary. Our talk today about the primary headaches, which is mainly is migraine, putting in mind there will be different types according to our diagnosis, retention, cluster headaches, putting in mind always that secondary headache is most important and to detect and diagnose. And so always there is a red flag list in headache diagnosis. Mainly is rapid onset of symptoms, thunderclap headaches, presence of neurological symptoms and signs, prominent neck pain with and without fever, age at onset more than 50 years old, worsening with positive changes and valsalva maneuvers, newly or worsening headache in patients with established chronic headache. In this situation, it will be thorough investigation needed and further assessment of our patients. So, as we know that headaches and migraine, it will be sensitization of the pressure will be the blood vessels within the neck, and again, it will be vasoconstriction, irritation of the nerves of the nerve vessels, and to narrow the blood vessels. The blood will be affected, blood circulation will be affected, and again, causing the headache attack or the migraines. Putting in mind that headache can be a symptom of illness, it's symptoms for the patient, migraine is the illness. So migraine is a complex, debilitating neurological disorder that affects nearly more than 1 billion individuals worldwide and result in total economic burden of approximately $17 billion per year. Migraine is not just about headache, it's highly disabling neurological disorder. Among neurological disorder, migraine is the second leading cause of years lived with disability worldwide. So always we should take care and stop when diagnosis of migraine, as it's one of the most disabling conditions in the world. 90% of living with migraine cannot function normally during their headache attack, or even during in between the attacks. Not just headache, a simple headache, it's a sum of migraine symptoms, which will be discussed. So migraine is the second cause of disability, and the first cause of disability in young females, especially between the age of 15 and 49 years old. Migraine can have a negative impact on the patient quality of life, affecting their ability to work, with relationship with their families and friends. The patients with migraine frequently withdraw from their family and social activities. So it may have a negative impact on patient quality of life and affecting their work and social life. Chronic migraine epidemiology and outcome studies found that patients with migraine frequently withdraw from their surroundings, with adverse effect on even themselves and other people. It's affect workplace productivity, and again, and they will have like a stigma of the surrounding that will not relate with their symptoms or disability and will withdraw from the society. Global prevalence of the migraine, it will be more than 10 to 20% that patients would have episodic migraine. More than 2% will be have chronic migraine. About 5% of episodic migraine will be changed to chronic migraine. About 3,000 migraine attacks per million person worldwide occur every day. So according to the WHO, these numbers are really disabling for the patients and economy. Usually it's common in the age between 20 and 55 years old, with female more 3 times more likely to suffer from men or male. 64% of severe headaches in female, while 43% in male. 75% of migraine patients are females. About 1 to 6 women has migraine headaches. Report incidence of migraine females of reproductive age has increased over the last 20 years, but this change probably reflects greater awareness of the condition and the proper diagnosis. So again, the migraine will evolve with age and gender difference according usually more female. Migraine with aura starts in early age in boys, while it will be late about puberty in females. Without aura, it will be a bit late and more common in females. Onset of migraine after the age of 50 years is usually rare and should suspect more further diagnosis. Few points about the history of migraine. The first descriptions of migraine can be tracked back nearly 14,000 years from the ancient Mesopotamia, during Sumerian Babylon, through Egyptian, Greek, and Roman times. 4,000 to 2000 BC, archaeological evidence suggests that Tripantion's form of primitive headaches or migraine was a hole in the skull and was the perimeter of the hole was the skull, as in this figure. It was used to treat migraine as surgical management. This shows that the person was survived after the surgery or after the treating of the headache itself. 460 BC, the father of medicine, Hippocrates, highlighted his own suffering from the attack of migraine. He described shining lights that was typically seen in one eye, followed by symptoms of migraine or the headache. The prominent Greek physicians, Galenos, first classified migraine as described in this at that time. Through the Byzantine, Arabic, and medieval times, there are only patches references until the 17th century, where the European physician first gave full of case reports of migraine. So in 1980s, research began to target the trigeminal vascular system in the brain's primary pain pathway, establishing the diagnosis of the migraine itself. Few points about the phases of migraine. So it will be like starting with premonitory phase or prodrome, that the patient will be sensitive to the stimulus or the triggering factors, including the light or sounds. There will be stiffness of the neck, mood changes, gastric upset. The second phase will be the aura. It will be slurred, humble speech, difficulty understanding, or like the patient will be confused, irritable, in some cases, problem in thinking, and including the visual auras and migraine with aura. So this figure, there will be some changes with vision, like you will not see the clear picture of any images, then most of the migraine patients will experience such figures in starting their migraine attack. The third phase will be the headache, where the patient will be more sensitive, worsening the pain and lights and sound. Usually he will be in silent and dark room and overcome his symptoms. The headache that can range from mild to severe according to the cases and the triggering factors and the medication which was already started, if it was started. Again, the fourth phase will be the recovery phase. According to it will be different from patient to patient, according to the time of each attack and the headache itself. Then after that will be the post-ROM effect, will be the patient will be tired, fatigued, generally unwell, and he looks lazy and feeling confused. In between the attacks, which we call the final phase, is called interictal phase. That's to say the mid-fuse between the episodes are with the attacks. Not always the story will be like all these phases in a regular way, but patient to patient. Both the prodrome and the postdrome can last for days or even sometimes more than a week. For some who get severe or chronic migraine attack, there can be no little gap between the migraine attacks and will be more continuous headaches and symptoms. So in summary, there will be that prodrome, it will be 3 hours, even to several days. Then about the aura will be a few minutes till 1 hour. The headache may extend for 3 days, and the postdrome phase will be about 1 to 2 days. The review of migraine of pathophysiology of migraine. Actually, the mechanism of migraine remains incompletely understood, although there is several studies and research about that, but still it needs a lot of work. However, new techniques have allowed formulation of current concepts that may explain parts of the migraine syndrome. Migraine pathophysiology is the result of interaction of neurons, glial cells, and the vasculature and the inflammatory signaling. There will be the central mechanism in the brain within the blood-brain barrier and the trigeminal ganglia and brain systemic vessels. The cortical spreading depression, also for neurologists or most physicians, they will be their spreading of the cortical. We'll know about the cortical spreading depression, excitation of the cortical gray matter that spreads from its site of origin at the rate of about 6 millimeters per minute. That intense depolarization of the neural and glial membranes, accompanied by massive disruption of ionic gradients and loss of membranes and resistance. So it's a complex mechanism affecting the pathophysiology of the migraine, but generally speaking, it will be more obvious and more and 2 points, that peripheral sensitization and again the central sensitization, affecting the spreading of the migraine itself, affecting the nervous system through the neurovascular mechanism. In this simple diagram, it will be the progression of the phases between the pathophysiology of the migraine according to the phases of the migraine. Recently, during the last few years, the role of calcitonin gene-related peptides in migraine pathophysiology was clearly understood and evaluated. So here there will be normal CGRP in a normal person, where the figure B, there will be increase in the CGRP, causing the pain and phonophobia, photophobia, nausea, and again, a triggering factor affecting the migraine or self. So CGRP will be levels during migraine will be increased in comparison to the normal at rest, according to the trigeminal sensory afferent. which this gives a hint for us to get proper preventive or prophylactic medication, which will be discussed by my colleagues later. According to the types of migraine, we have several types of migraine. The migraine without aura, which is called the common or typical migraine, and the migraine with aura, which is the classic migraine, where will be different symptoms, including visual or impaired vision, and even numbness, tingling, slurring speech, according to the type of the aura. There will be migraine aura without headache in several cases, although rare. Another case of migraine will be hemiplegic migraine. There will be a visual disturbance, sensory aura, motor weakness. Other type will be migraine with brainstem, ophthalmoplegic migraine. Well, just the symptoms will be mainly visual. There will be some retinal migraine and will be loss of vision transiently. Vestibular migraine, the patient will have several vertigo, nausea, vomiting, like symptoms of motion sickness. These are some types of migraine. In between, there will be intractable migraine or migraine status migraine. That's where the patient had severe attacks of migraine, mainly the headache, affecting more than 72 hours. Again, the last, most of about 5% of migraine patients will be the episodic migraine will be changed to the chronic migraine, which means more than 15 or more headache days per month, with mainly with all the symptoms or the headache specifically. So we can differentiate episodic migraine less than 14 days, while chronic migraine more than 15 days a month. And imagine 15 days he will spend headaches and symptoms, which affect definitely his life and the surroundings life. Diagnosis of migraine is most commonly symptomatic. First of all, concentrating on the symptoms, which will be fatigue, head pain, sensitivity to the light, smells, difficulty in concentration, stiff neck and feeling down or fatigue, and again with the associated symptoms. Always there should be a gap or interaction between the migraine and tension headache, affecting their psychomotor activity. The migraine differential diagnosis, the common types, which is tension headache, sinus headache, and the cluster headaches. And differential diagnosis of the persistent headache or chronic migraine, there will be hemicrania continua, newly diagnosed daily persistent headache, or chronic tension type headache. So accordingly to the symptoms and signs which we detect in our examination, and again putting some requests for the patient, including the migraine diary, putting in mind the medication overuse headaches. So this is just as migraine diary, the patient and from the patient, what's the causes, and you will return to us every month or 3 months according to the patient situation. And through these symptoms that will be affecting the migraine disability assessment, which affect the headaches on the patient lives, and we can even get further diagnosis. As part of investigation, we have, if we want to exclude other causes, blood test will be mandatory, and even brain imaging and cases which we suspect that will be not just simple migraine. Migraine could be emergency in 3 attacks, more than 3 days of the attack, or symptoms here including intense nausea, vomiting, other neurological symptoms or signs would be detected, presence of fever or other manifestation. There will be comorbidities of migraine. It will affect endocrinal symptoms, immune, skin, musculoskeletal, psychiatry, and neurological symptoms. In addition to the gastroenterology or gastric. So it could be participation with fibromyalgia, mood disorder, cardiovascular diseases, insomnia, and mood changes. Always we should check for the trigger factors in migraines, including different food, some types of red wine, cheese, sleep disturbance, uh, processed meals, and travel. So the patient with time will get know his triggering factor, and we should ask for specifically for some changes within or triggering for affecting his migraine. Most common is about stress, lack of sleep, anxiety, neck pain, dehydration, and weather changes. Our culture, most of the patients, and we notice that exposure to 5 to 10 minutes to sunlight may trigger the migraine attack. There's entities called the migraine estrogen connections in ladies, women, according to the menstruation headache or perimenopausal headache. All these should be emphasized in our talk, in our experience, and in our clinics, just to assess for the diagnosis and to get the proper diagnosis and management. Pregnancy and breastfeeding. Usually in pregnancy will be a break for migraines patients, especially during the second and third trimester, where this hormonal changes will be in favor of just to get calm of the headaches and pregnancies. Always we put in our mind that in such cases, pregnancy and breastfeeding, the medication of choice will be always just with benefit and risk for the patient, the pregnancy and the baby during the breastfeeding. Oral contraceptive pills and migraines, there is association in general for the vascular systems and again neurovascular and mainly migraine. Caffeine could trigger the migraine and some patients could be treatment for migraine. So it's always best to enjoy the moderation of caffeine. Burden of migraine, in general speaking, it's a burdensome condition, seriously debilitating condition, although being the third most common cause in the world, where migraine is often undiagnosed and untreated. In addition, its impact on both personal and professional life is not clearly underestimated. Migraine is the second cause of disability in the United States of Arab Emirates. Migraine has substantial impact on activity, daily living, including work, school, and social activities. Migraine may affect the patients and their families. It may be had psychosocial difficulties, including impaired energy and drive, emotional fluctuation, as well as impact on social functioning. It may affect potential abuse of medication used to treat migraine attacks, putting in mind the financial burdens of migraine on individual, family, society, and the global standard. So migraine is a major global health issue that affects 12% of population. It will affect more than 50% of patients report severe impaired on their need or bed rest. It will affect functional impairment, disrupted family activities. They will feel stigma for the disease, again for the comorbidities. So it will affect direct or indirect cost to the society. It affects and compromise a person's way of life, lost productivity and work, and individuals' ability to carry on their daily activity, task, and lead them to being stigmatized away from the surroundings. And thank you for thank you.
Yeah, thank you very much. Thank you very much, Dr. Atta, for a very nice presentation. You covered a lot during the allotted time. And now I think there are a few questions, but I think we'll leave it to the last, after the last second speaker. So now I will request Dr. Nabil Lakhawi. He'll be speaking on the migraine management and the unmet needs. Dr.
Yes.
Doctor, yeah, okay. Sorry, my video was, yes.
I will
So
share
now,
my
yeah, Dr. Nabil Lakhawi, he's a consultant neurologist at the Mirdef Hospital, and he will be speaking on medical management, as migraine management and the unmet needs. Yes, please, Dr. Nabil.
Thank you, Dr. Niaz. Thanks for the organizing committee for inviting me. So I'm going to talk about the unmet needs in migraine management. First of all, we should always think about migraine not as a symptom, but as a disease with different symptoms. This is very important. I'm gonna repeat some of the issues that Dr. Atta mentioned, just to follow يعني, the slides. We know that migraine, it affects almost 10 to 12% of the general population, more women than men. And this is related to the hormonal changes that women suffer from. We know due to public awareness that diagnosis is increased. So many patients, they come to you and they tell you that they suffer from migraine. But the problem that we still have issues regarding treatment. We know that migraine should be distinguished between two different types. This is very important, episodic and chronic. Dr. Atta mentioned that, but always not, we should not consider only the number of the attacks, because some of the attacks might have a duration of days. So always ask the patient how many headache you have monthly. Okay, because there is a relationship between the frequency of the monthly headaches and the severity of migraine. Of course, so the more the frequency of the monthly days headache is, the more the disease is disabling. And this will impact not only on personal level, there should be a burden on family, economic, and resource utilizations. We know that the migraine is the second or the third leading cause of disability worldwide. In the MENA region, it is the second leading cause. And we know that migraine, it affects mainly the young patients, mainly during the prime working years. So imagine how much it's gonna be disabling. So you can see here how much these are the differences between women and men, but always in younger ages. Many of the patients do not seek visits with the healthcare providers. And you can see this in different countries, in Germany, Italy, and other countries. And so many patients, they just, you have the medications, they can bring the medications from the pharmacist, from the supermarket, and many of them, they do not seek visits with the healthcare providers, specialists, or with the general practitioners. It's important to recognize the frequency of the monthly day headaches, and we can distinguish this in low when the number of the monthly days headache is below 5. So up to 4, it's a low episodic migraine. It's intermediate when it's between 5 and 9. And it's high frequency episodic migraine between 10 and 14. So this is very important, because the more the frequency is increasing, the more the disease is disabling, the more the disease is not responding to the acute medication or to the prophylactic medications. We call it chronic migraine when you have more than 15 days monthly headache for at least 3 months, and 8 of these days should have migraine features. We know that those who have high frequency migraine, they behave as the chronic migraine. And these patients, they have at least one unmet needs. And we will see this later on. What are these unmet needs? So here, this slide shows the relationship between the frequency of the monthly days headache and the disability. Okay, the severity of the disability. And you can see that the more is the frequency, the more is disabling the disease. Of course, in those with a high frequency, especially in those with chronic migraine, 61% they have severe disability. So how we treat patients with migraine? We know that we have the acute treatment and we have the prophylactic treatment. When we use acute treatment, we call it abortive treatment because we want to abort the pain. And but this is very important that the medication that we use should relieve the patient from pain within the first 2 hours, and the effect should be sustained for the next 24 hours. And it should be it should be efficacious also with at least 3 attacks to consider that the medication is effective. And when we use prophylactic treatment, always our aim is to reduce frequency, severity, so the intensity, the duration of the attacks, and of course, to reduce disability and to reduce the resource utilization, especially the ER. Okay. So this is when we have to offer preventive treatment for the patients. This shows that if you have 2 severe attacks, you can offer the patients 2 severe 2 days headache monthly. You may offer. If you have 3 and 2 of them severe, you may also offer. But I know, many colleagues and even me, when I have a patient with even one attack, which has a long duration, which has severe symptoms, usually I offer. But we will see why the American, they choose a cutoff of at least 4 days monthly headache to start offering prophylactic treatment. We will see this later. So according to the American Headache Society, when you have at least 4 days monthly headache, you should offer prophylactic treatment. In the acute treatment, we have different options. So we have the NSAIDs, we have the triptans, we have the antiemetics, we have the ergot, the alkaloids, but we are not using them anymore. And we have the different types of medications for the prophylactic treatment, the beta blockers, the anticonvulsants, the calcium channel blockers, the antidepressants. Today we have the CGRP monoclonal antibodies, and we might use also antihypertensives such as candesartan, lisinopril. For the chronic migraine only, we can use also botulinum toxin, Botox. So if we look to the statement in 2019 from the American Headache Society position, so patients who have at least 4 or more headaches, you should offer prophylactic treatment. And if we look to this epidemiological survey, the Cameo study, which was done in 2012 and 2013, among the 16,789 patients, 39% they have at least 4 headache days per month. Means that 39% of our patients, we should offer them prophylactic treatment. Among those who are eligible for preventive treatment, 80% they are not using medication, and 64% they have moderate to severe headache-related disability, and only less than 10% are using oral preventive therapy. And those who are using preventive therapy, they discontinue, half of them discontinue the medication because of safety, tolerability, and efficacy concerns. This is another survey from the AMPP, the American Migraine Prevalence and Prevention. They also found that almost 39% of the patients should be considered for preventive treatment. And in this survey, 12% they were using prophylactic medication, but 26% they used and they stopped the medication because of the side effects and tolerability. But we know that many of our patients, when you start using the medication, 50% of them, they stop the medication after 1 month. And after 6 months, only 25%, they are still using the medication. And at 12 months, only 14%. And you can see here that these are 3 different prophylactic treatments: the antidepressant, the anticonvulsants, beta blockers. So they all overlap. So all of them, they overlap. And this means that independent from the type you are choosing, independent from the type of the medication you are choosing, unfortunately, compliance is reduced and many patients discontinue the medication. This is when you ask why the patient stopped the medications. This is regarding antidepressants, anti-epileptic medications, the beta blockers, the calcium channel blockers, because of lack of efficacy and because of the side effects. Okay, if we ask the patient their attacks, how much the attacks are disabling, so we can see that almost 54%, so 50% of them, they have severe disability and often it requires bed rest. Only 7% they have functionally normal, and 39% they have some impairment. So just not to, you will not remember the numbers, but just to remember that at least 50% of the patients, they have severe disability in the chronic and episodic migraine. You know that we use the, I personally use for all my patients the MIDAS score, and Dr. Atta talked about it a little bit. In the questionnaire, we asked the patient if they have absenteeism from their job or if they have 50% reduced productivity. Of course, those with a chronic migraine, this slide shows how many hours, the mean hours lost per person per year. So in the chronic migraine, almost they lose 85 hours yearly. They are totally absent from the job, and reduced productivity almost 256 hours. Of course, it's less in the episodic migraine. Dr. Atta also mentioned how much the disease is disabling, and it's disabling not only on the patient himself, but also in the relationship between patient and spouse. And this will create often some problem between the couples, especially when the spouse doesn't believe anymore her husband and that he's suffering from migraine. So it may create a problem. And also the effect or the relationship patient-spouse, they ask for their children. And in many cases, patient feels guilty and that he would be a better parent if he is not suffering from migraine. So there is an important impact on work, important impact on leisure activities and on the family. So there are unmet needs in when using prophylactic treatments, and we know that if you use any medication more than once daily, patient usually is not compliant, and the current prophylactic treatment, they are not well tolerated, and the reason that they have many side effects, the reason why many patients discontinue the medication. And especially when the patient is not responding to the medication, the patient is using repetitive acute medication, and this is associated with medication overuse headache. And always we have a challenge finding the right medication, because many times patients are suffering from comorbidities. So I use the beta blocker many times, especially women, they have hypertension. So when you use beta blocker, you may increase the hypertension, this for example. And so on. So there is an important impact on quality of life. But why we should use preventive treatment? We should use preventive treatment to improve the quality of life, especially because almost we have loss of work for at least 4 hours for the episodic migraine and 8 hours for the chronic migraine, and to prevent the chronifications, okay? Chronifications means to prevent conversion from episodic migraine to chronic migraine, okay? And this why happens, I'm not gonna discuss about it, but imagine that there's always a neurophysiological changes, anatomical changes, and neurochemical changes happen in these patients, okay? And we know that 50% of the patients will discontinue prophylactic treatment within 60 days, but according to the study that I showed you, 50% they discontinue the medication within the first month. So what are the targets of acute treatment? Of course, we need rapid onset of action. That's why this is the reason why we have oral dispersible treatment for the medication, and many times we use intravenous medication when the patient comes to the ER or comes to our clinic. So we need a rapid onset of medication. We need consistent freedom from pain and associated symptoms to restore ability to function, minimize repeating the doses and the rescue medications, reduce the use of health resources, and minimize the side effects. Now let's look to the recommendations from the American Academy of Neurology and AHS guidelines. So whenever we have a migraine patient, we ask the patient if he's responsive to a certain medication, paracetamol or any NSAIDs. We ask the patient to continue with the same medication. If the patient is not responding, we might go further to another medication such as triptans or combination treatment. We should always take into consideration the comorbidities the patient suffer from, the contraindications, and so on. We should limit the use of opioids. Tramal, don't use tramal, because always patient may benefit at the beginning, but then he will have the rebound effect, and the abuse and the addiction that might cause these medications. We should always consider patients suffering from peptic ulcers, renal diseases, and we should always avoid medication overuse headache. That's why we should limit the use of acute medication to 2 or 3 days weekly. What are the limitations of acute treatment or with the acute treatment, the currently used medication? Unfortunately, many of the acute medications, and especially when they are used long-term, they are associated to medication overuse and the risk of transformation from episodic to chronic migraine. The current medications, they may abort the headache, but they do not prevent recurrency. They have inconsistent efficacy. Sometimes they work, sometimes they do not work. They have slow onset of action. They cannot be used, especially the triptans in the patients with cardiovascular diseases, and their use should be restricted to 2-3 days weekly to prevent medication overuse headache. We have many unmet needs in acute treatment. Of course, if we look to the in the survey of the AMPP, 56% of the patients, they respond that they have inadequate relief. And from the cocaine review oral triptans, we know that 43% they experienced adverse events when using triptans. And the recurrence in patients using triptans within the first 24 hours is between 17 and 40%, depending on the type of triptan used. If we don't have a good response, of course, this is associated to unmet needs. We know that 2.6 million of the Americans, they suffer, they have cardiovascular disease, and they also suffer from migraine. So we should choose a medication which works for this category of these patients. Of course, if we have unmet needs, means we have great disability, we have a great burden. And these are also numbers coming from the migraine in America symptoms and treatment study. At 95%, they have at least one unmet needs. We discussed that we have an issue with the rapid headache onset with the medication available. The attacks, mostly they are moderate to severe, 55%, inadequate 2-hour pain freedom, 49%. The headache recurrency within 24 hours, 38%. And what they found that the greater the number of the unmet needs, the greater the worsening of psychological symptoms, attack-related cutaneous allodynia, and migraine symptom severity. This is a very important slide because in this study, they saw the percentage of patients converted from episodic migraine to chronic migraine. So we have almost 3% of the patients in 1 year, they converted from episodic to chronic migraine. And what they found that there is a relationship between their response to the acute treatment and the risk of progression to chronic migraine. So if you have good response to the acute medications, so the risk to convert to chronic migraine is low. But if you have poor response to acute medication, the risk is very high. So what, this is also a survey for these patients. So patients, what they need a complete pain relief, no recurrency, rapid onset of actions, no side effects, a read of associated symptoms, and easy route of administration. So we have different medications in the market. We have the triptans, we have the ergots and the dihydroergotamine, the cafergot. We are not using it anymore. The NSAIDs, the non-specific options, the combination analgesics, the non-invasive devices, the oral ditan, and today we have the oral CGRP antagonist, the GPANs. So regarding triptans, of course, we have to be careful using them in patients with peripheral artery disease, in cardiovascular diseases, in patients with hypertension. The NSAIDs careful in gastrointestinal diseases and renal dysfunction may worsen hypertension, increase the risk of medication overuse. The lasmiditan, the ditans mentioned before, of course, those when administered for 8 hours, they should not drive and they should not operate machinery. They should not operate machinery. GPANs, no issues. And of course, the narcotics and the barbiturates, we should limit their use, and they are not indicated in the acute treatment of migraine. The GPANs, they were discovered in the 80s, actually, the GPANs, but at the beginning they had issue hepatotoxicity, and then recently the FDA approved a new medication. I think Dr. Muhammad Harb will talk about it, and it's FDA approved for the treatment of migraine with or without aura in adults 2019-2020. There's no apparent vasoconstriction, so it seems that we can use it in cardiovascular diseases. And it might be ideal when triptans are contraindicated, not tolerated, or not effective, and we can use them in refractory cases. So today we discovered the CGRP. The CGRP, it's the most powerful vasodilator. Mainly it's found in the trigeminal ganglion. And we have experience using the monoclonal antibodies against the CGRP. And I think it changed the history of the treatment of migraine. And today we have the oral medications, the GPANs. They are anti-receptor CGRP. They are good in the acute treatment and good in the prophylactic treatment. So now that we know the pathophysiology, the role of the CGRP, we can better modulate migraine, resolving the unmet need, both in acute and prevention stage. Thank you very much.
Thank you very much, Dr. Nabil, for a very nice presentation. I'm glad that both of the speakers, they finish their talk within a time, and we have now, instead of 10 minutes, we've got more than 15 minutes for a question answer session. So now there are a few questions in the chat box, but I would like to request all the participants and attendees that if they've got any questions or queries, they can write in QA, and the speakers will be glad to answer their queries and questions. So now we have got a few interesting questions. Let us answer those first, and then I also have got a few questions. Would like to really know your comments. Now, one of the attendees have asked that is there any surgical intervention to be done to help the patients with migraine? So I think maybe Dr. Nabil will be the one to answer.
Yes, surgical intervention, there's no surgical intervention, but we have other issues that we can use. Sometimes we might use the nerve conduction block, the occipital nerve conduction block, which may help. We have the non-invasive devices that we are using nowadays, sometimes in case the medication are not working. But today, since we understand the pathophysiology of migraine and we know what are the main target, so the medications, believe me, the medications are very efficacious. And I think the history of treatment of migraine changed, but there's no specific surgical intervention for migraine.
Yeah, I think, maybe the problem is, I mean, as a physician, because I also look after general medical cases, you see, I think the education is very, very important. And when you are talking with, especially when the patient is, these migraine patients they may be hovering around different doctors because it's one of the chronic elements, they may be seeing the different doctors. I think it's very, very important for a physician really to talk to the patient in detail and to get the details of the detailed description of the migraine headaches, what have been done. So how important do you think is this education for the diagnosis of the patient? Because it's very, very important to diagnose whether the patient has got one of the type of migraine, what are the particular risk factors, and are we dealing with a migraine or is something else going on with the patient? So maybe I would like to have a comment from both the speakers on this question. Role of
Dr.
education.
Atta, will start.
Yeah, please, Dr. Nabil. Can start first.
Yes, of course, it's very important to discuss with the patient, share with them, even the pathophysiology. Today, everyone, they read, they Google everything. So many patients, they ask you what's happening, why I'm not responding to the medication. I'm seeing here in Dubai a high frequency of patients suffering from migraine, and many of them, they are refractory. We were talking before we start that I was in Lebanon, I worked in Italy and in the States, and really the frequency, what I'm seeing here in Dubai, we have a high frequency of migraineurs. Today, thanks for the new medication available, and when we talk about the pathophysiology, we always have different alternatives. I always speak about the pathophysiology, even with the patient, I explain to him. And I try to, the patient usually when it comes to you, they tell you that I suffer from migraine. They know the symptoms of migraine, okay? And I believe, what's happening today when we are giving the any medication and we are seeing the response, the patient is telling you that the 2 or the 3 types of headache that I have disappeared. So there's a question mark also about the tension type headache. They are named tension type headache, but they might be, part of migraine. And I remember that we discussed this even with many doctors, that we are seeing this. Patients are telling you the tension type headache, what we call tension type headache, disappeared. The headache in my in this area radiating to the neck and the shoulder disappeared. The typical throbbing headache orbital disappeared when you are using, especially when you are using a successful treatment. And one of the successful treatment we are using today is the anti-CGRP. I don't know if Dr. Atta agrees with me.
Well, actually, yeah, definitely I agree with you, Dr. Nabil. And we are lucky that most of our patients, they are educated here and they know what's going on, their attacks. And definitely when they heard about a new medication either by friends, by information, by Google, whatever, they will come to seek this medication. And I agree definitely with this new medication. It was a lot of progress and improvement in attacks. We have patients, they are suffering really. And I had at the beginning of starting this new medication, I had one of the young patients, he had suffered a lot with his family and with his work, and it was a lot of complaints. He's not working, but unfortunately, some people, they don't know migraine is migraine, like a zombie. They just say, oh, it's just headache. Why you're not coming to work? But again, with this medication, and maybe within 2-3 months, he returned back to his life, and he progressed in his work and with his family. Really, I put this example as a patient and treatment of migraine. So he will be happy, and we will be happy, and again, for society and all.
We should always, think about when we ask the patient the question, how many attacks? We shouldn't ask how many attacks. Sometimes the patient tells you, I have 2 attacks only. Ask him how many days headache you have monthly or weekly. Okay, this is very important. And then we have to learn about the effect of the headaches on the quality of life. These are very important keys because they will help understand how is the response to the medication. The frequency, there is a relationship between this high frequency and the quality of life. We should always address these questions to our patients. And when giving the medication,
yes, sorry.
yeah.
Yeah,
Also,
because we have a lot of questions, so can you just please wind up the answer, because we have got a lot of questions coming up now. Yeah. So one more question is coming, that is there any yes, I think Dr. Shirin is there. Can headache be due to the brain? Sorry, can headache due to brain tumors mimic that of migraine? So,
Well,
Dr.
actually, yes. Depends, as we mentioned in headache classification, there's primary and secondary causes. From our side as physicians in general and neurologists, from detailed history and again physical examination, well, definitely there will be a focal sign or something to irritate us. From a clinical point, we'll ask for brain imaging. I agree, some patients were treated as migraine maybe several months or years. By doing brain imaging, there is some brain pathology. But again, maybe clinically they were bilateral symptomatologic examination, no focal deficit. The headaches were not so progressive or new onset, but still, I think MRI brain will be clarify that at least there's no brain lesion.
Yeah. So thank you very much. The another question is, someone has commented, I think Dr. Ahmad Hijazi, is mentioned that 14 migraines is called episodic and 15 migraines is chronic. So they are doubting that this is very difficult.
From clinical point, yes, but according to the classifications, chronic migraine is defined as having at least 15 headaches per month, with at least 8 days of having continuous headache with migraine features and other symptoms for more than 3 months. So this one is called chronic migraine. And as Dr. Nabil just when he emphasized on 3% episodic migraine will return back or will progress to chronic migraine. So our role is to prevent being chronic migraine, which will be more difficult to be treated.
I think there's another very important comment he has mentioned, which is, I think I would like to answer, because they mentioned what about the collection of different types of headache. Because many of these patients, they may start with migraine, and once they know about the diagnosis, maybe if it's not properly treated, it may convert into a kind of a not only drug overdose medication headache, but maybe it's depression and tension type, maybe added on it. So how do you manage these patients? How do you differentiate this? Because I personally think many times patient may take undue advantage of the diagnosis, and sometimes this diagnosis may be misused, so therefore I think sometimes very difficult for even general physicians or general internists, to separate which one is migraine headache and which one is contributed to by tension headache or a depression or some other psychosomatic reason.
Yeah, definitely agree for this point, because always there is some points in communication between the migraine and tension headache. And definitely in migraine patient, they will develop tension headache. And simply had headaches attack, the stress with the stress of work, life, whatever, there will be tension headache. So there will be some points that will be similar and against. So according to the judgment and correct diagnosis, it will help. Again, migraine headache, will be there is association with tension headache.
Dr. Nabil, any comments?
I agree with them, and what we are facing. Many patients, they are coming with the different features of headaches. We have the features of migraine, we have the features of medication overuse headache, and we have the features of tension type headache. Surprisingly, when you are using the medications, especially like botulinum toxin or any efficacious prophylactic treatment, all the 3 types of headache reduces in frequency, reduces in intensity. So it will help all the different types. The question, is this what we call the tension type headache? Is it part of migraine, or is it type of medication overuse headache? You know, it's always very difficult, you know, to distinguish the feature. But what we know and what we are really practicing right now, that we have important reduction of all these types of headaches when we use medication, especially with the anti-CGRP.
Yeah, that's the reason you see I was stressing the role of education, because it's very, very important that you listen to the patient, and then the patient should listen to the doctor also. Very, very important to really find out. And I think that is very, very important for the general physicians and family physicians also, to talk to the patient, to explain what is going on. And sometimes a good talk or good listen to the patient will really sort out many simple missing links in these so-called difficult to treat patients. Yeah, so there's another question. I think they are coming out of the diet. So what is the role of magnesium or a riboflavin or any prevent in any specific diet which you recommend for the treatment or prevention of the migrainous headaches? So first of all, maybe Dr. Atta might comment on these things.
Well, actually, yes, definitely. A good point that, as we mentioned, most of our patients, they know that what's the triggering factors for their headaches. So diet, I think one of the most important trigger factors, as we know that cheese, some dark coffees, chocolates, whatever. So it depends from patient to patient. Well, he should avoid the triggering factor. Again, there is some rule of other associated, like, for example, gastrointestinal diseases, celiac disease. So he should be aware enough of the correlation between this and the migraine attacks. I think my colleagues and I have some patients with celiac disease. Simply when he had started gluten-free diet, the headache was gone, really. So diet, healthy lifestyle, some meals, heavy meals, or fast food should be avoided in such patients. Dr. Nabil, maybe can add.
Yeah, definitely.
experience.
You know, the lack of sleep. This is very important. Some types of food, the yellow cheese. Okay, I always tell my patients to eat white cheese. The sunlight. You know, I really find it here in UAE, because in other countries we don't have it. But many patients, they come to you and they tell you that sometimes even the flash of light, not only the exposure 5-10 minutes, the flash of light can trigger migraine. Some certain perfumes, I always tell my patients not to skip meals. We don't know if it's the hypoglycemia which triggers migraine, but definitely when they skip meals, the frequency increases. So we should always tell our patients about to discover the triggers. And we can help them, but usually they tell you, when you ask them, is there anything triggering the attack? Sometimes they tell you, sometimes we try to help them and they tell you, yes, doctor, you are right. When I don't sleep, the day after I have migraine. Okay, so different issues. And sometimes we help them, you know, giving melatonin, for example, for those who have difficulty sleeping, it will help. Melatonin, there are some studies which show that it works as prophylactic treatment. Stressful events, the reason why sometimes magnesium might help. Sometimes we use magnesium high doses for our patients. So, you know, it depends, you know, usually we should individualize the prophylactic treatment for these patients.
What about the treatment? They are asking, there's a magnesium or riboflavin, any specific role for as a treatment?
I have never used them, but they are written, you know, in some of the in some guidelines.
Okay. So there's another question about using the medical instruments separately. Any comment? I'm not aware of the separately as an additional treatment.
I'm aware that there are different devices. They are called non-invasive devices. Like some of them, they use the magnetic field, and some of them, like the vagal stimulations, sometimes use the stimulation of the occipital nerve. Honestly, I'm not using them, but we should start using them in some of our patients, because we were discussing in the last conference with some of our USA colleagues, and they are finding some good results. And I think we have 2 devices here in UAE.
Yeah. So there's one important question from the general practitioner, I think very important, that which patients should be referred to neurologists? Or do you want every headache patients to, or every patient diagnosed with migraine should be referred to neurologist?
Well, actually, as a neurologist, I'd say yes. But definitely, I think a good number of neurologists in UAE preferable to neurologist. But during my practice in UK, I think most of the migraine was treated by the family medicine and the general practitioner.
That's more logical, I think.
Yeah. But again, for maybe for more further opinion or more experienced opinion, definitely the neurologist will be the choice.
Yes, I think it's very, very important. So I think we have already passed the time. So thank you very much for both speakers. You presented your points very well. And thanks again, Dr. Atta and Dr. Nabil, for the nice presentations. And so we have got now another speaker. This is last. So Dr. Mohammed Harb will be the one speaking now. His topic is many migraines needs one simple solution, the role of Remigipine. So Dr. Mohammed Harb is a consultant neurologist at American Center of Psychiatry and Neurology, Abu Dhabi. So over to Dr. Mohammed Harb, please. Thank you. Sorry, you are mute. I think so.
Oh, sorry.
Yeah.
Again, thank you, Dr. Niyaz, for this nice introduction. It's my pleasure to join this amazing meeting and to present my lecture about many migraine need one simple solution, role of Remigipine. As a neurologist, the incidence of migraine in our population is very high. It's about 10 to 15%. And every time when a patient came to my clinic suffering from recurrent migraine attacks, my own problem or my own concern, how to choose for him the effective and appropriate acute and or preventive treatment. As you know, the treatment is divided to 2 types. We have an acute treatment and we have the preventive treatment. Acute treatment, it is a first-line treatment. The main concern for it, the main purpose of prescribing acute treatment is to relieve the symptoms of patient, but its limitation are side effect or ineffectiveness. Concerning the prophylactic treatment, it is prescribed for patient having recurrent headache attacks. The main purpose of prescribing this kind of medication to decrease or to improve the decrease frequency and the intensity of migraine, and also for the disability. But its limitation also, like acute treatment, we have ineffectiveness and side effect. For this, when I have to choose an acute and or prophylactic treatment, my choice is based on 4 important factors. Each treatment should be, first of all, effective. Second, it has rapid onset action. Third, you have no side effect. And fourth, it is easy to use. Why I am insisting in these four important criteria. Because first of all, if I have a patient suffering from chronic migraine headache and I prescribe for him an effective appropriate treatment, I have 74% chance of transforming his chronic migraine headache to episodic migraine headache. But in the other way, if the patient is suffering from episodic and I prescribe for him inefficacious treatment, I have chance of 8% of transforming the episodic migraine headache to chronic migraine headache, taking also in consideration the dropout of patient taking preventive treatment. All studies showed us and only 50% are taking their prophylactic treatment after 2 months of treatment and 10% only after 6 months. This was related to two main issues. First of all, ineffectiveness, and second, appearance of major side effect. Now, is it our approach to treatment of migraine still based on old-fashioned, or we can use now the new fashion? And what about, is there any magic pill that combine the acute and preventive treatment on the same time? Yes. Rimgepant is the first and only medication proven to treat and prevent migraines. If patient is candidate for only for acute treatment, we can prescribe for him Nurtec. And if we have patient are candidate for preventive treatment, we also can prescribe Nurtec. For this, it is a dual treatment. We can use it as acute treatment and or preventive treatment. Why? Because Nurtec, it is fast and last. Because when we give the patient the Nurtec, it takes 60 minutes, above 60 minutes to work, and the majority of patients taking the acute treatment Nurtec, they have resolving of their pain and returning to the back to normal in 1 hour. And this magic effect lasts for 48 hours. And if we patient are given them the Nurtec as preventive treatment, its preventive effect started to work within 1 week. For this, Nurtec, we can use it as to treat and prevent. For this, FDA give Nurtec as the license as indications for patients suffering an acute treatment with or without aura, or as a preventive treatment for episodic migraine headache. This magic pill came to fix the unmet needs associated with traditional acute treatment. With the old traditional acute treatment, we have up to 45% of patients experience adverse event within 24 hours. We have up to 82% of patients experience return of their pain within 24 hours. We are abusing as traditional medication, and we have a high chance of developing medication overuse headache. In addition, we have some patients that are contraindicated to prescribe him some kind of acute treatment. What is the main goal of prescribing acute treatment? As simple as we have rapid and consistent freedom from pain, return to normal life, minimal need for repeated dosing and rescue medications, reduction in healthcare resources used, and having or not having any adverse event. This concerning the acute treatment. What about preventive treatment? The main goal of prescribing patient for preventive treatment is the reduction of the frequency and overall impact associated with migraine, and preventing the overuse acute medication. In addition, transforming the simple migraine to medication overuse headache. But unfortunately, with the old medications, we have some problems. We have delayed efficacy, we had poor tolerability, which this explained the high discontinuation rate with this medication. For this, I put in the first of my presentation, only 50% of patients taking preventive treatment within 2 months, and only 10% are still taking their medication after 6 months. Taking also in consideration the popcorn use of headache medication taken by patient to abort his headache. In addition, taking in consideration also that the daily number of medication taken by a patient having other than comorbidity like hypertension, asthma, dyslipidemia, diabetes, and other. Also, as Dr. Atta and Dr. Nabil mentioned in their presentations, we have a low number of patients who are candidate to take their preventive treatment they are taking in their life. We have only 50% of patients are taking their medication. Here, Nurtec came to resolve these two problems with the acute and preventive treatment. It can give began this dual treatment in patient candidate for acute and or with preventive treatment. Now, how this magic pill works? Now, as Dr. Atta and Dr. Nabil mentioned, the main issue is targeting GCRP, calcitonin gene-related peptide. Nurtec will block the receptor of this mediator. By blocking this, the receptor of this mediator, we have three important issues. We have inhibition of vasodilatation, but in meantime, will not have active vasoconstriction like triptans. In addition, we have inhibition on neurogenic inflammation, and finally, we have inhibition of exaggerated pain signaling. Now, by Nurtec, we can treat migraine attacks. In addition, we can prevent the next one from happening. For this, when prescribed Nurtec to our patients suffering for migraine, we have 86% of patients do not take a rescue medication with significant pain freedom, free of most bother symptoms, and we have a pain relief. And this act will start as I mentioned in the first 60 to 90 minutes. It peaks to 2 hours and lasts for 48 hours. For this, in the first week, when we are prescribing this magic pill, we have a significant reduction in migraine daily headache. This one was observed in the first week, even it was observed up to the week 9 and 12. And this sustained efficacy was observed until 1 year of treatment. For this, when we have this dual action, we can prescribing this effective treatment as an acute treatment and also as a preventive treatment. What about side effect? The good news about rimgepant, we have a low percentage of side effect. We have the two most side effects observed with Nurtec are nausea and abdominal pain and dyspepsia, but they are very little. What about discontinuation rate? It is very minimal, less than 2.7% of patients had to discontinue their treatment with Nurtec. And this also, what about long-term side effect? this study showed us that the majority were very minimal. We have nausea, dizziness, bronchitis, back pain, influenza, but they are very mild. By this dual mechanism, a dual therapy, we can use Nurtec to fit our patient's need. Like Ivan, he needs as abortive treatment or acute treatment. Also, Ellie, she needs her Nurtec for her only for attacks during menstruation or during exam. Tia, she needs her treatment as prevention. And finally, Jennifer, she needed also as preventive. For this, we can use this new medication as a dual effect, as acute and or as preventive. And now, how the Nurtec came? It came in a box with 8 tablets. We can prescribe the acute treatment as needed. For patient having episodic migraine headache is a candidate for preventive treatment. We can prescribe the Nurtec Q other day, and we can prescribe it for at least 9 to 12 months. And now the new recommendation from the European Headache Society is much better to keep the patient suffering from episodic and or chronic migraine headache for at least 12 to 18 months. To summarize, Nurtec, it will block the GCRP receptors. It is dual action. It works in acute treatment and also as a preventive treatment. And also it is very safe, and it is associated with low discontinuation rate. Thank you so much. I'm ready for any questions.
Thank you very much, Dr. Mohammad Hab. It was very brief and brisk presentation, very nice to the point. So I think the 1 or 2 questions are there in the chat box. So one thing is, someone is asking that, is it safe to use in children?
No, until now, it did not get the approval from the FDA for children, even for the anti-GCRP like Aimovig or Emgality or Vyepti. Until now, it is not prescribed for children populations. Meanwhile, we have trials they are conducting for this kind of patient, but until now we do not have any result concerning the safety of this kind of medication in special population.
Yeah. So, and what any other contraindication for the use of these things?
Usually no. We have to be very cautious concerning interaction with cytochrome P4A2. That's it.
Yeah. And someone has commented, Dr. Ahmad Hijazi, that how do you compare this with the other longer acting preventive prophylactic agents like the eptinezumab, because you have to give every 3 months for other than this.
Now we have a trial called the Challenge Migraine. It is started in November 2021. It is a trial comparing the efficacy of Emgality versus Nurtec. But until now, we don't have the official result concerning this comparative trial.
Okay, so, and then they're asking about the pregnancy. I think you already mentioned.
Concerning the pregnancy and breastfeeding, it is contraindicated to use this kind of medication like the other new medication like Erinimab, Emgality, and Vyepti.
Just from my side, one practical question. Do you think this is the one answer for many questions, this medicine?
It is a magic pill. Combining on the same time the acute treatment and preventive treatment.
In clinical practice, for example, which would be an ideal patient to be a candidate for this Nurtec? Classical case. Yeah.
Okay, the new recommendation for the European Headache Society, they recommend as first-line treatment anti-GCRP. like Irinimab, like Emgality, and like Vyepti. Now, concerning how to choose between these four products, until now, our experience with these products are very modest. As you know, this medication came to our market 3 to 4 years. For this, with time, maybe we will have the more experience how to choose between this medication, which patient need this medication, not the other. But some patient they're having phobia for injection. For this for this kind of patient, we can prescribe Nurtec for them.
Yeah, I think the difficult patients will be those who have been suffering from migraine for last many years. They have tried so many drugs over the counter by the different doctors, and when they are listening and taking these new medicines, I don't think so it will be a one answer, but I think what perhaps may be required will be this will be an additional armament which will perhaps cut down half of the other medication he has been tried. Sometimes, so I personally think, can it be used alone? May not be. Sometimes you may still require some of the other medications. What is your opinion? Because I don't have any personal experience, but this is my just assumption.
Okay, let be clear. Do we have how the mechanism of action of old treatment in migraine? We don't know.
No, yeah.
Enderal, triptizol, valproic acid. The only medication we know how kind of bit works in migraine is Topamax by inhibition of cortical spreading. But the other medication, until now, we don't know how it works during migraine. For this, now with this new window in treatment of migraine with anti-GCRP and knowing the exact pathophysiology of GCRP, now we are dealing with the main cause of migraine. And anti-GCRP like Aimovig, Emgality, Vyepti, even with Nurtec, we are hitting the mediator who is responsible for the migraine pathophysiology. For this, now comes a new recommendation for the European Headache Society in choosing as the first line anti-GCRP as a prophylactic treatment, but with Nurtec, it has dual action as acute and or preventive treatment.
Yeah, I think very well said, because this is the beauty of this product, because it can be used for the treatment as well as for the prevention. And because we are targeting the pathophysiology, whatever we have known so far, so it sounds very logically to prescribe these medicines.
In addition, Dr. Niaz, its effectiveness lasts for 48 hours.
Yes, that's important. Yeah.
It dissolves in 10 to 15 seconds, start working about maximum 30 to 60 minutes, peak 2 hours, and last for 48 hours.
48. Yeah. So there's another question they're asking: is if get toxic dose, any antidote for Nurtec?
Usually, until now, we don't have any data about overtoxicity with these medications, and now we don't have until now any antidote for it.
Okay, so I think I cannot see any other questions. So it looks like, so we have got a very good participant list today. More than 200 people participated in this. Yeah. So it is, I think all three speakers were really great. They presented their topic very well, and a lot of interest was generated, as mentioned in the question answer session. So I would like to thank again all my dear three colleagues, Dr. Atta, Dr. Nabil, and Dr. Mohammad Harb for their presentations. And I would like to also to thank the Society of Internal Medicine for, for providing me chance to discuss this very important medical element, you can see, and to see you, all my colleagues there. So I think with this, we can wind up the session. We are finishing a little bit earlier, 5-6 minutes earlier, but no harm. And I think I should thank the participants also, because this is a weekend and they just took time out of their weekend. And so just thanks very much, everybody, and hope to enjoy your rest of the week. Thank you, everybody.
Thank you all.
Thank you.
Be safe. Thank you.
Bye-bye. Have a nice night. Bye-bye.
Bye-bye.